hello everyone. Happy evening, a very good evening. I hope and I believe all of you are doing well. A quick note, everyone. Am I audible and visible? Okay, that's great. So I hope all of you are doing well, guys, and preparing well for your upcoming exams. So here we are into the score booster session, the 100 one-liners in radiology. These are the most important, the must-know, the 100 one-liners. So, the unusual thing about this session is you will not see a lot of images per se, but you will see a lot of facts that are important in radiology. The science and all is what we are going to see, right? So let's start discussing the 100 one liners here. So tell me that you have no ionizing radiation in which investigations we have no radiation. Which all investigations there's going to be no ionizing radiation? Yes. Very good, Om Prakash Sharma, absolutely right. So it's going to be UST and MRI, right? This is one of the very basic questions, but very, very important question, which is asked very frequently in the exam. There is no radiation in ultrasound and MRI, and that is why we do ultrasound and MRI in pregnancy. When I say ultrasound, so also remember Doppler because it is ultrasound. Also remember FAST because it is focused assessment sonography for trauma. That is not going to have radiation. And when I say MRI, it also means MRCP because that is again a type of MRI. Okay, so ultrasound and MRI have no ionizing radiation. Next one. So tell me that what is the most sensitive investigation for air containing pathologies, fluid, calcification and soft tissue? Yes. Very good. Air is CT scan, correct. Correct, Rachna. Fluid is UST. Calcification is CT, UST, CT, MRI. Absolutely right, SS. So for air, remember CT scan is the investigation. That's the most sensitive. For fluid, remember fluid has U in its spelling. It is going to be USD. Calcification is C. It is going to be CT. And for soft tissue, it is going to be MRI. What comes in soft tissues is muscles, nerves, ligaments, tendons, cartilage. All these are best seen on MRI. Okay, so please remember these basics because when you are given a patient who has meniscal tear, ACL tear, right? So you are going to do MRI there to look for the meniscus and the ligament. Okay, so soft tissue is MRI. Absolutely right. Okay. Going to next one, what are the things which are hyperdense or non-contrast CT? What things are hyperdense or non-contrast CT? Very good. One is hemorrhage. When very good, specifically it is acute hemorrhage. And what is the other thing? That is bone. That basically means calcification. So what is hyperdense or non-contrast CT? Very, very important. Remember is acute hemorrhage and calcification. Okay, calcification appears white. Acute hemorrhage appears white, not chronic hemorrhage on CT. And that is why for acute hemorrhage and calcification, we can just do NCCT as the investigation. Like for urinary tract calculi. Okay, renal calculi, ureteric stone, you can do CT, not contrast CT is enough for that. So remember, it's acute hemorrhage, which is hyperdense, not chronic hemorrhage. So next one, look at the image here, which is showing you that how this is acute hemorrhage appearing white, hyperdense on CT. And this one here is the calcification that you are seeing white on CT. Can someone tell me what calcification is this? Can someone tell me what calcification is this? Is this physiological, pathological, and what is the site of the calcification here? What is the site of calcification here? Very good, Dr. Alia. Absolutely right. Correct. This is third ventricle. Behind the third ventricle, posterior to third ventricle, you have the pineal gland. So, this is one of the physiological sites of calcification. This is pineal calcification. Okay, what is this? This is pineal calcification. Alright. So, this one is acute hemorrhage. Okay, this one is acute hemorrhage. Next one, what is the radiological investigation that is done for CSF leak? Yes. What is the radiological investigation done for CSF leak? Very good. It is, see, what you will not contrast, and CT, Dr. Alia, when we say the contrast is given IV. Here, when I want to see from where the CSF is leaking, right? For example, there's CSF rhinorrhea. So, in that case, I want to make CSF white. Okay, so I want to put the contrast in the CSF spaces. That is done by doing lumbar puncture. So, that's basically CT cysternogram or MR cysternogram can be done. Okay, CT or MR cysternogram is cysternogram is what is done. Where you do lumbar puncture, you put the contrast in the subarachnoid space, the CSF space, you give head low position to the patient, right? All the contrast will go into the CSF space, and then you give the prone position to the patient and you would see the CSF leaking out. From where the CSF is leaking out, you can make that out. Okay, so remember, for CSF leak, we do cysternography, CT or MR cysternography, correct. So, we are on the topic of investigation of choice. What is the investigation of choice for stress fracture? X-ray, CT, MRI, ultrasound. What is the investigation of choice for stress fracture? Very good. For stress fracture, it is MRI. It's a very small fracture which might not be seen on CT. But it does have the surrounding bone marrow edema. Remember, wherever you want to see marrow edema, M for M, it is going to be MRI. So, investigation of choice for stress fracture is MRI. Investigation of choice for vestibular schwannoma. Where do you see vestibular schwannoma radiologically? What is the location that you talk about? It's a tumor occurring where? What is the location of vestibular schwannoma? Yes, when it is bilateral or multiple, you will do a bone scan, because bone scan will scan all the bones at once, right? So, but if it's a localized unilateral, then you would do MRI. Very good, Khalaik, absolutely right. It is CP angle. Cerebellopontine angle mass hota hai ye vestibular schwannoma, right? What appearance does it give? What sign does it give? Ice cream cone appearance. Remember the mnemonic, the trick to remember it is eating ice cream and eating shawarma. Okay, schwannoma is shawarma. So, shawarma and ice cream, right? And so, what is the investigation of choice? It is going to be MRI. Okay, it is going to be MRI in the brain. Remember, MRI gives you a better detail as compared to CT. But when it's an emergency condition, like, a stroke, you will first do CT, because CT is faster, MRI takes longer time. So, always in emergency, we prefer doing CT. So, remember, it is MRI with contrast or without contrast. It is going to be MRI with contrast. When do I do a contrast scan? The general principle is, if there is any mass, any tumor, anywhere, you have to do a contrast scan, because it helps you to delineate the mass very well, right? If it's an infective pathology, inflammatory pathology, you do contrast scan. Okay, is this clear, Zishan? So, CECT or even MRI contrast is done anywhere where there's a mass, there's infection, there is inflammation. Okay, so remember, you will do MRI with contrast. And in which condition do you see bilateral vestibular schwannoma? In which condition do you see bilateral vestibular schwannoma? Very good. It is NF2. Remember, bilateral is two sides, so it is NF2. Okay, not NF1. Bilateral vestibular schwannoma is NF2. Correct. What is the sensitive investigation for avascular necrosis? AVN, avascular necrosis. What is the sensitive investigation? Very good. Again, it is MRI, because early AVN again starts with bone marrow edema, right? The late changes, the collapse, the sclerosis, all those late changes which are picked up on X-ray and CT, they are the late changes. But if you want to pick it up early, you will have to do MRI. Okay, it's MRI. CT is investigation of choice for which bone tumor. Okay, so for bone tumor, when you want to see the extent and everything, you do MRI. But for which bone tumor do you prefer doing CT? Okay, SS stir. Stir is the sequence which is done for bone marrow edema. Okay, to look for bone marrow edema. Because what is a stir sequence? Is a fat suppressed sequence. So it suppresses the normal fat like the marrow fat. So imagine that you have marrow fat and in that marrow you have edema as well. So what happens is the fat and edema both are appearing white. Okay, on T2 weighted, the fat is appearing white, the edema is appearing white. So you are not able to differentiate this is marrow fat white or edema white. So what do you do is you make the marrow fat black by suppressing the fat in the stir sequence, and that is how the edema will stand out. Right, I hope this is clear. So whenever you want to pick up this bone marrow edema, right, you will do a stir sequence. Okay, a stir sequence. Correct. Osteoid osteoma, Malaysia nahi. Osteoid osteoma is where you do CT. Why do you do CT for osteoid osteoma? Sorry, please bear with my sore throat and some cough and cold. Guys, right. Because it's a cortex-based tumor, and that is why you do CT for osteoid osteoma. Absolutely right. Next question. What is the best investigation for bronchiectasis? Correct. It's going to be HRCT and not biopsy. Right? Because in HRCT, you can see even the small peripheral bronchi very well. So remember, it is HRCT for bronchiectasis. For which other lung condition do you do HRCT? For which other lung condition HRCT is very, very important? One is bronchiectasis. Other one is interstitial lung disease. Okay, so the concept is basically where you want to see the lung architecture, you would do HRCT, right? So for bronchiectasis, ILD, you will do HRCT. Okay, you will do HRCT. Correct. What is the investigation of choice for posterior urethral valve? Is it IVP, RGU, MCU? Very good. You guys are awesome, right? You know all of this. It is MCU. Please do not get confused that it's a urethral pathology. So do not mark the answer as retrograde urethrogram. It is micturating cystourethrogram because posterior urethral valve is a one-way valve. Right? If you will do RGU, the valve will open and you will the valve will open and basically you will not see any obstruction. The obstruction comes only when the urine is coming from the bladder into the urethra. That happens in micturating cystourethrogram, right? So remember, it is MCU, which is the investigation of choice. If I ask you the question that what is the investigation of choice for VUR? What is the investigation of choice for VUR? Again, for VUR, it is MCU. When the bladder, there is micturation happening, that is when the reflux happens. Okay, with the micturation, the reflux happens. Okay, pylogram you cannot do, right? Zishan, understand the term pylo, matlab pelvis, renal pelvis is what you see in the pylogram, right? So when I talk about pylogram, like IVP, you will see the kidney, the ureter and the bladder, right? You are not seeing the urethra there. Okay, all right. Going to next one, some important points about lung cancer. What is the investigation of choice for lung cancer? Lung air containing, you do CT for lung, right? It's a cancer, it's a mass, it's a tumor. So you will have contrast enhanced CT. Okay. But if the question is, what is the gold standard for lung cancer? Okay, Rachna, remember that if it's an investigation of choice and gold standard, investigation of choice is generally a non-invasive. If it is sufficing, we will try to do that. Gold standard is generally the invasive one, which is biopsy. What biopsy do we do for the lung? CT guided biopsy. Okay. What is the investigation of choice for staging of lung cancer? For staging, where all the lung cancer has spread, right? For any cancer, basically you do a PET CT. Nowadays, you combine PET and CT together, it's going to be PET CT. Okay. And for which lung tumor specifically do you do MRI? MRI is done for which lung tumor? Very good, Jayashree, Namami, absolutely right, Dr. Ansha, correct. It is done for Pancoast tumor, right? Why? Because it invades the brachial plexus, right? The Pancoast tumor at the lung apex, it invades the brachial plexus, the nerves which are best seen on MRI. And what is the classical history given in Pancoast? This is one of your recent NEET PG exam question. Pancoast has history of invading the brachial plexus. So upper limb pain is going to be there. Sympathetic trunk is also there. So there's going to be Horner's, right? There's going to be history of Horner syndrome, history of upper limb pain. All that history is classical of Pancoast. Okay, that is Pancoast. Next one. What test should be done before giving IV contrast in CT scan? Very good. You should do RFT, KFT, which is basically simple blood test, which is done for that is serum creatinine. Because these contrasts have renal excretion, right? So the renal function has to be good before giving this IV contrast. What contrast can you give in renal failure? Renal failure safe contrast is USD contrast, MRI contrast, CD contrast. This is one of your NEET PG or INI-CET exam question. The contrast which is safe in renal failure is USD, CT or MR. Very good. Very good, Namami Sharath again. It is USD contrast. Why USD contrast is safe? Because it is excreted by the lungs, right? These are microbubbles excreted by the lungs, not by the kidney. So USD contrast is safe here. Next one, test done before doing PET. If you are doing FDG PET, what test will you do before doing the FDG PET scan? Right, the blood glucose levels of the patient will be seen because you don't want the blood glucose levels to be high because the cancer cells will take up blood glucose rather than taking up FDG. So you do not want the false negative results there, and that is why the blood glucose needs to be seen. Next one, TLD badge is monitored how frequently? Right, the TLD badge, the thermoluminescent dosimeter, which measures the dose of radiation exposure, it is measured monitored how frequently? The radiation exposure which is occurring. Very good. That is 3 months. Okay, check the image of the TLD badge. You would see it is like April to June, October to December. Okay, so remember it is monitored every 3 months. TLD has 3 words. Remember it is 3 months. Okay, Dr. Renshaw, do not forget TLD is 3 words. So it is 3 months and not 6 months. Contrast used in esophageal perforation. What contrast will you use in esophageal perforation? Very good. We will use iodinated contrast and we will not use barium. Very, very important. Barium is contraindicated in perforation. In iodinated, the one which is commonly used, it is iohexol. If iohexol is not in the option, then you will go with gastrographin, which is again the brand name of iodinated contrast, but iohexol is non-ionic and it is safer. Okay. So iohexol more than gastrographin. If iohexol is not in the options, then you will go with gastrographin. Okay. Next one, which is the isoosmolar iodinated contrast? Which iodinated contrast is isoosmolar? Very good, Prateek. Absolutely right. It is iodixanol. Okay, iodixanol. So we have discussed this in our videos on PrepLadder app, how to remember the various contrast media, the easy tricks, which is ionic, which is non-ionic, monomer and dimer. Can you tell me? Very good, Sharath. So what kind of contrast is it? Iodixanol, ionic, non-ionic, monomer, dimer. Correct. IOD has di in its spelling. It is a dimer. It has OL in its spelling. OL wale contrast media are non-ionic. Okay, it's a non non-ionic dimer. Okay, it's a non-ionic dimer. This is basically your iodixanol. What is the iodine particle ratio for iohexol, which is the most common iodinated contrast medium? What is the iodine particle ratio of iohexol? 3:2 or 3:1? See, iohexol again is non-ionic. When I say non-ionic, it gives one particle, right? So, it's not going to be two particles. It is going to be one particle. Everybody else is clear. Please watch that video of contrast media to understand the tricks in detail. Non-ionic means it's like one complete particle. It is not dissociating into two particles. It is one particle, right? This is going to be 3:1 because it's a non-ionic monomer. When I say monomer, it will give 3 iodine. Okay, non-ionic will give one particle. It is 3:1 guys, not 3:2. Two particles are given by ionic contrast media. Okay, not by the non-ionic ones. Okay. Next one, coming to some important points in radiotherapy and nuclear medicine. Acute radiation syndrome, which occurs when the radiation dose is more than how much? More than 1 gray, right? What is the sequence of involvement of the various systems? If I talk in terms of GIT, CNS and hematopoietic syndrome, what is the first one to be involved? GIT, CNS, hematopoietic. What is the first one to be involved? Nahi, Jayashri, it is not going to be GIT first. Remember that bone marrow is the most sensitive tissue. Most radiosensitive is the bone marrow, right? So, first is going to be hematopoietic, that is bone marrow suppression. Okay? Then it is going to be GIT and then it is going to be CNS, the law of Bergoni that we have. The actively dividing cells are radiosensitive. The cells which are not dividing are less sensitive or resistant. Neurons do not divide, they are more resistant. Bone marrow always dividing, it is going to be sensitive. Okay, so remember it is hematopoietic, GIT and CNS. The neurons comes the last. Next, this has been asked in both your NEET PG exam, INI-CET or FMG में भी पूछा गया, important. If distance doubles, radiation intensity reaching a point becomes how much? Is it going to be just half, Dr. J? If distance doubles, radiation intensity reaching a point becomes half, 1/8. 16 times reduce हो जाएगा. कितना 16 times नहीं, कितना times होगा? Yes, Kalai correct. It is going to be reducing, right? It is going to be 1/4. Very good, Nirdai, Kanupriya, correct, Yamini. See, what is the name of the rule that you have here for the distance and the radiation reaching a point? It is something called as inverse square law. Okay, it is something called as inverse square law. So, as the distance increases, obviously the radiation reaching a point will decrease. Jitna you will go away from the radiation source, you will receive less radiation. How much less? It is inversely proportional to the distance ka square, 1/d square. So, if you are making it, if the distance is becoming half, then it is going to be 4 times. If the distance is becoming 2x, then it is going to be 1/4. Distance is becoming 3 times, it is going to be 1/9. Okay. So, if the distance is doubling, that is 2x, this is going to be 1/4. It is inverse square law. Is this clear with everyone? Right. Next one, what nuclear scan is done for parathyroid adenoma? Nuclear scan, this is like the favorite for the examiners. It is SISTA-MeB scan. SISTA-MeB, sometimes in the exam they can just give as MEB. And even in SISTA-MeB you have SPECT and you have scintigraphy, right? As in INI-CET, ये दोनों options थे, which is better? Scintigraphy is better or SPECT is better? SPECT is going to be better than Scinti because SPECT is like a CT and scintigraphy is like a X-ray. Okay, CT gives a better resolution, so SPECT is going to be better. What tumors are FDG PET negative tumors? Right, first of all, tells me, are these going to be low-grade tumors or high-grade tumors? Which tumors are going to be FDG PET negative? Low-grade or high-grade? Right, it is low-grade tumors because the tumors which are like similar to the normal cells, they are like low-grade tumors. They will not, treat a lot like behave a lot like the cancer cells, right? So they will appear negative on PET, right? So remember, low-grade tumors or well-differentiated tumors like carcinoid and in the lung bronchoalveolar carcinoma. Even in the carcinoid, it is typical carcinoid, which is well differentiated carcinoid, which is going to be PET negative. Okay, so the low grade well differentiated tumors, they are going to be PET negative. Okay, can you tell me where in the body can you have physiological uptake in the PET, physiological increased uptake in PET? Physiological increased uptake in PET can be seen in what area in the body? Brain. Okay, where else? Very good. The supraclavicular, the brown fat here, if you see bilateral supraclavicular increased uptake, it's normal, right? अगर एक side पे है, so then you are worried, but if it is bilateral, then it is okay. So brain, supraclavicular region, even the kidney, because it is getting excreted by the kidney, the urinary tract, right? The kidney, the bladder, okay? So remember, supraclavicular is something that you should remember. Next one, what is a nuclear scan which is done for bones? For osteoporosis, the drugs that you have is bisphosphonate. So similarly, the nuclear scan for bone that you have is diphosphonate scan. Okay, so MDP scan, HMDP scan, HEDP scan, DP, diphosphonate is the DP scan. Okay, it is technetium 99 diphosphonate scan, which is done for bones. Okay, right. What is the most radiosensitive and most radioresistant cell cycle phase? The most radiosensitive is G2M and the most radioresistant is when the cell is not actively dividing. It is the S phase, which is the most radioresistant. Okay, right? SS, you are correct that sodium fluoride PET is done for bone mets, but we spoke about the nuclear scan, that's a scintigraphy. Okay, so that is why the answer there was MDP. Most radiosensitive and most radioresistant tissue. This is bone marrow, right? And the resistant is the neurons. Okay, the neurons are the most resistant. If you have gonads in the option, you have bone in the option, and they ask you which of the following is most sensitive, then the answer is going to be gonads. Okay, because when you talk about bone per se, you are not just talking about bone marrow, but the bone cortex as well. Okay, bone marrow is sensitive, bone cortex is not that much sensitive. Okay, so gonads will be a better answer than the bone. Which tumors are most radiosensitive and most radioresistant? What is the mnemonic that we have seen? Welms is sensitive, Morph is resistant. Okay, you have Wilms, Ewing's, lymphoma, multiple myeloma, seminoma, melanoma, osteosarcoma, renal, pancreas and hepatic. Okay, HCC. So remember, Welms is sensitive and Morph is resistant. Okay, right. Next one, what is the nuclear scan for Meckel's diverticulum? What nuclear scan is done for Meckel's? Remember, for MEC, it is TEC. Okay, so it is technetium 99 per technate scan. Okay, it is technetium 99 per technate scan, which is done for Meckel's. MEC is TEC. Okay, very good, Nirday. Remember, MEC is TEC, so it is per technate scan. What is the nuclear scan for LV function? This is one of the previous FMG exam question. For left ventricular function, what nuclear scan is done? HIDA. Can I remember HIDA is for biliary tract, not for the heart. HIDA is for biliary tract. For the left ventricular function, what is the name of the scan, guys? Very good. It is Muga scan. Okay, it is Muga scan. Thallium scan is for helping you differentiate whether it is ischemia or infarct, a reversible defect, irreversible defect. Okay, ischemia hai ki infarct hai. Muga is what helps you to measure the ejection fraction, which is the left ventricular function. So basically it helps you to measure the ejection fraction, that is Muga, multiple gated acquisition. We use RBCs here. Okay. Next one, in which condition do you have cold spot on the bone scan? Which condition gives cold spot on bone scan? Very good, multiple myeloma, because in multiple myeloma you do not have new bone formation to give a hot spot. It is just the lytic lesions in the bones, there is no new bone formation. So multiple myeloma gives cold spot, very, very important. Next one, what is the half-life of iodine 123? What is the half-life of iodine 123? Guys, just give me a minute. Yeah. Sorry for that. I got some urgent call. So tell me. Yes, half-life of iodine 123 is 13 hours. Absolutely right. This is the ideal radioisotope for the diagnostic scan. Okay. So remember, for iodine 131, which is used for treatment wale ka half-life will be longer in days. It is 8 days for iodine 131 and 13 hours for iodine 123. Next one, Bragg peak is seen with, one of the recent NEET PG exam question. Bragg peak is seen with Br, remember Bragg, Br is seen with Pr, that means it is seen with protons. Okay, Bragg peak is seen with protons. Is this clear with everyone? Yes, absolutely right. Then you have, what is a non-invasive investigation of choice for myocardial viability? For myocardial viability, what is a non-invasive investigation? What do you do for myocardial viability? Now, see, should I only understand the fact that thallium does not help you to differentiate it's a hibernating myocardium or it's an infarct. So, you need an investigation which helps you to differentiate it is hibernating, it is normal, or it is infarct, right? The three of them. So, it is going to be PET scan where you have, you do perfusion ke liye also and metabolism ke liye also. Okay, perfusion, metabolism, you look for the matching and mismatching. That helps you to identify whether it's hibernating, it's infarct, it is normal. Okay, so it's a PET scan which you have both with perfusion and metabolism. Okay. Next one, which radioisotopes are pure beta emitters? They emit just the beta rays. This is commonly asked PYQ question. Remember PSY, psychiatry का जैसे PSY होता है. So pure beta emitters is PSY, phosphorus 32, strontium, and you have yttrium. Okay, and you have yttrium. PSY, very good. Okay, now coming to the next system, that is respiratory system that we are going to have a look at, right? So what is the sign of pneumothorax on USD, right? So now it's going to be all the systems that we are going to see. Very good. It is going to be barcode sign, right? Barcode sign, also called as stratosphere sign. Okay, it is the barcode or the stratosphere sign. And the most specific, absolutely right, you have the presence of lung point. Okay, lung point presence. So look at this one. What are you seeing here? You can see the transition that will happen between the barcode and the seashore, which is normal. This is lung point. Okay, this is how the seashore is. Look at the lower part, the granular appearance, and this is the barcode, which is more flatter line. Okay, more flatter line. Okay. Next one, in what condition do you see continuous diaphragm sign? See, Som Subra, if the question is what is investigation of choice for pneumothorax? The first investigation is going to be X-ray, right? If it's a patient with blunt trauma, then you have EFAST, which includes evaluation for pneumothorax, and you have the most sensitive, which is going to be CT, okay, which looks at the air very well, right? Continuous diaphragm sign? Very good. It is seen in pneumomediastinum, right? Pneumothorax nahi, pneumomediastinum. If this is the heart, this is the diaphragm, in between the two, there is this air which is present, right? So that is where basically you will have continuous diaphragm sign. The heart and the diaphragm are separated by the air. You can see the diaphragm in continuity because of that. So remember, it is pneumomediastinum, not pneumothorax. Very, very important. Hemidiaphragm sign or double diaphragm sign? Okay, Shipra, double diaphragm is seen in pneumothorax. There is no hemidiaphragm sign per se. माउंट फ्यूजी साइन नहीं, देखो माउंट फ्यूजी याद रखना कि इधर है हमारे हेड में, ब्रेन में. सो न्यूमोकेफेलस में है. ओके, जब टेंशन न्यूमोकेफेलस होता है यहाँ पे ब्रेन में, तो यहाँ पे होता है माउंट फ्यूजी साइन. सो माउंट फ्यूजी इज इन द ब्रेन, एयर वाला इन द cephalic cavity, that is pneumocephalus. Okay, that is pneumocephalus. Okay. Next one, what is the sign in X-ray or CD chest which helps us to differentiate a given pathology that is seen and opacities that we are seeing? Is it parenchymal or is it extraparenchymal? Monisha, angel wing sign, okay, that's the thymus separated. That's also because of the pneumomediastinum, right? The thymus is getting separated by the air because of the air. So angel wing sign भी दिखता है pneumomediastinum में. Neclario V sign दिखता है. कौन सी साइन है जो बताती है कि ये पैरेंकाइमल पैथोलॉजी है, कि लंग पैरेंकाइमा से ये आ रही है या ये लंग पैरेंकाइमा के बाहर से आ रही है? व्हाट इज दैट साइन व्हिच हेल्प्स अस टू डिफरेंशिएट? That is air bronchogram sign. Correct. So, Subra, you are correct, right? But you just have to label the sign. The name of the sign is air bronchogram. If in an opacity you are seeing the black bronchi going, right? Bronchi are present in the lung, not outside the lung. So if you see that bronchi going, then it is going to be intraparenchymal pathology. So air bronchogram sign is present in intraparenchymal pathology, not extraparenchymal pathology like pleural effusion or mediastinal mass will not have it. Silhouette sign, Anukriti, Yamini, remember? Silhouette helps you to localize the pathology in terms of the lobe of the lung, right? So if there is silhouetting of the right heart border, it is right middle lobe. Left heart border is lingula. It helps you to localize which lobe it is, okay? Right. Can you see this black bronchi in this opacity? So this is basically air bronchogram that you are seeing here, telling you this is intraparenchymal, this is consolidation, okay? Consolidation, pulmonary edema, pulmonary hemorrhage, right, hyaline membrane disease. There are multiple causes of air bronchogram, but it is not seen in pleural effusion. It is not seen in mediastinal mass, okay? Right. If you see a coin which has a circular view on AP view, then where is that coin located? Coin circular. Remember, circular on AP, circle is the esophagus. Okay, circle is the esophagus. So remember, circular coin on the AP view, that is going to be esophagus. Okay, so that same coin on lateral view will be slit like. right? And if you see the opacity which does not have a single ring but a double ring appearance, then what foreign body is it? Remember, double ring appearance or halo sign is button battery. Double ring or halo sign is button battery. Okay. So look at this one, AP पे circle, lateral में slit. This is going to be coin in the esophagus. If asymptomatic, you can leave it as it is, but you cannot leave button battery because it is a corrosive. Next one, coming to the musculoskeletal system. What is the diagnosis here? Yes, what is the diagnosis here? Very good. This is ankylosing spondylitis. You are seeing dagger sign which is present, the white line in the center, the bamboo spine, the fusion of the vertebra which is happening. This is ankylosing spondylitis. The term tells you it is ankylosing, that is fusing the spine, the inflammation of the spine, fusing the joints, fusing the spine. Where does it start? At what joint? It starts at the sacroiliac joint. The low backache is what the patient gets. There is morning stiffness because it is inflammatory arthritis. Any inflammatory arthritis like rheumatoid, ankylosing, they will have morning stiffness. Why does it have red eye? Because it has extra articular anterior uveitis which is common. Okay, anterior uveitis which is common there. Okay. Next one, where do you see hair on end skull appearance? Hair on end skull is seen in just a minute. Not able to see the live chat. Just a minute, guys. Correct. Hair on end skull. Remember, hair on end, HE. This is seen in any hemolytic anemia because of the increased hematopoiesis, right? So, it is seen in thalassemia, sickle cell anemia. Hemolytic anemias will show hair on end, or it is also called as crew cut appearance. Where do you have cotton wool skull? Cotton wool appearance. Cotton wool skull is seen in Paget's. Okay, remember Paget's has cotton wool skull. Paget's is both lytic and blastic. So, cotton wool is seen in Paget's. What is the lytic lesion? What is the name of the lytic lesion in the skull seen in Paget's? Anyone? अगर स्कल में लाइटिक लीजन दिखता है पेजेस में से, बड़ा सा लाइटिक लीजन दिखता है फ्रंटल पैराइटल बोन में, उसका नाम क्या होता है? टैमोशेंटर इज द लाइक द हैट, द ओवरग्रोइंग ऑफ द बोन, ऐसे फ्रंटल बोन ओवरग्रो कर रही है, वो टैमोशेंटर उसको बोलते हैं. ठीक है, इसका नाम क्या होता है? लाइटिक लीजन वाले का नाम क्या होता है? वेरी गुड यामिनी, करेक्ट. इट इज ऑस्टियोपोरोसिस सर्कमस्क्रिप्टा. Okay, osteoporosis circumscripta, which is seen in Paget's. Pepper pot skull, PP parathyroid is seen in hyperparathyroidism. Tiny, tiny lytic lesions. For which bone tumor do we do RFA? Radiofrequency ablation is done for which bone tumor? Anukriti beveled lesion is seen in LCH. Langerhans cell histiocytosis, वहां पे दिखता है. नहीं जीसीटी के लिए नहीं करते हैं. वेरी गुड नमामि, करेक्ट. इट इज ऑस्टियोइड ऑस्टियोमा, ओ. वेर यू हैव ओ के अंदर ओ, मतलब वो जो कॉर्टिकल थिकनिंग है उसके अंदर छोटा सा नीडस होता है. यू वांट टू अब्लेट दैट स्मॉल नीडस, राइट? सो दैट इज व्हाई यू यूज आरएफए. इट इज फॉर ऑस्टियोइड ऑस्टियोमा. नेक्स्ट, very good. Fallen leaf sign is seen in simple bone cyst, also called as unicameral bone cyst. Okay, simple bone cyst or unicameral bone cyst. The other name for this is trapdoor sign. Okay, trapdoor sign. Correct. Next one. Where do you see Scotty dog sign? This is interesting. Where do you see Scotty dog? Listhesis में दिखता है. Right. So finally, I've got the answer. Nirday is correct. Remember, Scotty dog is seen in a normal spine. Each one of us, if we have a lumbar spine ka X-ray oblique view, each one of us will have this Scotty dog sign present in us, right? Remember, हम सबके अंदर वो कुत्ता है, right? So remember, it is Scotty dog is present in all of us. So Scotty dog is normal, but when it is Scotty dog with a collar, collar is what tells you कि इसका neck fracture हो चुका है, मतलब lysis हो चुका है. It is seen in spondylolysis, spondylosis नहीं, spondylolysis. ठीक है. So Scotty dog is normal lumbar spine oblique view, but if you see a collar, the break, then it is spondylolysis. If you see beheaded, then that means it is listhesis. Okay. Spondylosis nahi, spondylolysis. Next one. Coming to the renal ke thode one-liners. If you have a fat containing lesion in kidney with history of seizures, what lesion will you think of? Very good. It is angiomyolipoma. Okay, angiomyolipoma, which is generally associated with especially bilateral tuberous sclerosis. Okay, that is tuberous sclerosis. How do you identify fat on CT? Fat is white or fat is black on CT? How do you identify fat on CT? Fat. Very good. It is dirty black appearance. Okay, dirty black appearance. Jet black is air, fat is dirty black. Why do fat and air appear dark on CT? Because they are less dense than water, right? So both of them have negative HU value. Okay, both of them have negative HU value. Fat, your recent NEET PG exam question, -50 to -100 के बीच में होता है HU value of fat. 50 to 100, -50 to -100. ठीक है. Next one, so look at this one. This is the ultrasound. This is a kidney showing a hyperechoic lesion in the kidney. Fat is white on ultrasound. It is this dark, dirty black appearance on the CT, which has the vascular component also. So it will have the dirty black appearance and the white component also. Okay. Next one, if you have a patient who has history, complaint of hematuria, and there's a solid renal lesion which is enhancing, then what will you think in that case? Then it is going to be renal cell carcinoma. Why? If it would have been non-enhancing renal lesion, if it would have been non-enhancing, then you would think of renal cyst, right? A simple renal cyst. But if it is enhancing solid hematuria, then you think of RCC. Correct. Then you will think of RCC. So look at this one. यहाँ पे ये kidney है, उसमें ये mass है, ये से enhancing areas है, necrotic areas है. This is going to be RCC. Okay, RCC. Next one. If there is an adrenal lesion with light bulb appearance on T2 MRI, then what is that lesion? Adrenal lesion with light bulb appearance on T2 weighted MRI, appearing white, very white like a light bulb on T2, that is going to be pheochromocytoma. Okay, that's going to be pheochromocytoma. Remember, for pheochromocytoma, the screening investigation is urinary VMA levels, metanephrin level, but when you want to localize, first you do is adrenal MRI. Okay, adrenal MRI. If you have a lung cancer patient who has adrenal lesion, you know that lung cancer में meds, adrenal meds बहुत common है. So there's a patient of lung cancer, you are seeing an adrenal lesion, the HU value of which is 2. Then what is the diagnosis there in that case? What is the diagnosis in that case? Small cell? No. Specifically, when I'm telling you that the adrenal lesion has the HU value of 2. So that is what you have to remember. Any adrenal lesion which has HU value which is less than 10, that is a incidental वाला जो lesion होता है, adrenal adenoma, the most common incidentaloma in adrenal, right? Majority of your adrenal adenomas are lipid rich, they are fat rich, and that is why they have low HU value, right? So if anytime you see adrenal lesion less than 10 HU value on a non-contrast scan, it's an adrenal adenoma. You don't have to worry about it. It's not a adrenal metastasis. Okay, this is very, very important. बहुत साल पहले एम्स के एग्जाम में पूछा गया है. ओके, दिस इज वेरी वेरी इंपॉर्टेंट. सो दिस इज जस्ट अ डिस्ट्रैक्टर व्हिच माइट बी गिवन इन द क्वेश्चन कि लंग कैंसर का पेशेंट है और एड्रेनल लीजन है. सो डू नॉट ऑलवेज मार्क इट एज मेटास्टेसिस. इफ द HU वैल्यू इज लेस देन 10, इट्स अ एड्रेनल एडिनोमा, लिपिड रिच, which are generally non-functioning. Majority of them are non-functioning. ठीक है. Next one, drooping lily appearance on IVP. Yes, absolutely. Any PYQ asked anytime has to be remembered. Drooping lily appearance, right? Droop is seen with dupe, that is duplication or a duplex moiety, complete duplex moiety, complete duplication. Ureterocele में क्या मिलता है? Ureterocele तो cobra head होता है. Ureter का dilatation appears like a cobra head. Ureterocele is cobra head, right? Coming to CVS system, what is a normal arterial and venous waveform that you generally see? Artery, if I talk about the limb artery, okay, we are talking about the Doppler limb Doppler. Normal limb artery में कैसा waveform होता है? Monophasic, biphasic, triphasic? It's a triphasic waveform. ठीक है? Forward, backward, and again there is forward. It's a triphasic waveform. Venous waveform normal is monophasic with respiratory phasicity. It changes with respiration. Okay, so look at this. If you see the waveform like this, this is going to be arterial waveform. Okay, and look at the venous waveform. ये baseline के यहाँ है, बस ये एक ही direction में है, and it is showing the phasicity. It changes with respiration. Okay, next one, enlargement of which heart chamber causes esophageal indentation? If this is the heart on the CT with the 4 chambers, this is where you have the esophagus, and this is what is the left atrium. Left atrium is close to the esophagus. So remember, it is left atrium enlargement which can cause esophageal compression. Or vice versa, if the question is asked, this is one of the FMGE PYQ, that for which chamber you can do transesophageal echocardiography. Transesophageal echocardiography is done for LA, right? जब LA thrombus देखना है atrial fibrillation के पेशेंट में, तो हम transesophageal echo करते हैं. ठीक है? Next one, obliteration of retrosternal space is seen in enlargement of. So sternum के just पीछे ये space obliterate हो गई. तो कौन सा chamber है basically which is retrosternal? Anterior most chamber of the heart is right ventricle. Okay, so right ventricle, retrosternal, it is anterior most. Left atrium is posterior most. Right atrium nahi, right ventricle. Next one, where do you see boot shape heart? Boot is seen in TOF. Why do you see boot shape heart in TOF? Previous NEET PG exam question, because of RVH, which takes the apex of the heart upwards like a boot, upturned boot. Okay, so boot shape heart is seen in TOF because of the RVH, right ventricular hypertrophy. Where do you have snowman heart? Like a snowman, the appearance is there, snowman heart. ये है heart और basically ये है vertical vein going into the superior vena cava. That's the abnormal drainage of the pulmonary vein. It is seen in TAPVC. What type? Supracardiac type. That is type 1. Okay? So remember, snow falls from above. So supracardiac TAPVC. Okay? Snow falls from above. Egg on side, egg on string, TR. This is seen in transposition of great artery, which generally has associated history of maternal diabetes. Okay? Maternal diabetes. TGA में generally history दी जाती है बच्चे की, न्यूबॉर्न है, immediately after birth cyanosis हो रहा है. TGA is very common. Okay, TGA is common. Next one, box shaped heart is seen with Epstein's. And Epstein's is a teratogenic effect which is seen with lithium. So box-shaped heart is seen with Epstein's and it is a teratogenic effect of lithium. Next one, what is the diagnosis here? What is this condition? Very good. Absolutely right. This is coarctation of aorta, which affects the blood supply in the lower limb, and that is why the lower limb blood pressure is decreased, right? Because there is narrowing after the subclavian artery. The upper limb is normal. The lower limb is receiving less blood, and that is why there is intermittent claudication. There is inferior rib notching because of the collaterals. Remember, it is inferior rib notching, not superior rib notching, because vessels are along the lower border. Okay, coarctation of aorta associated with Turner syndrome. Okay, it's associated with Turner's, right? It's also called Riesler's sign. Hypertensive patient with acute chest pain and unequal blood pressure in upper limbs. What is the diagnosis that you think of here? Correct, ABCD. Correct, anonymous. Dr. Debeki, 3 sign, reverse 3 sign is what you see. Correct. You are thinking of aortic dissection because hypertension is the most important risk factor. Okay, right? There is acute chest pain like MI, and but the blood pressure in the upper limb can be unequal. When this is the history given, you think of aortic dissection. What investigation do you do here? CECT. If the patient is stable, if the patient is unstable, then you go for TEE, right? Transesophageal echo. If the patient is unstable, if the patient is stable, then you will go for CT. Okay, then you will go for CT. Next one. Silhouette sign with loss of right heart border tells you the pathology is where. If this is the heart border, this is the right heart border, and you have a opacity which is obscuring the right heart border. So basically, where is the pathology? Very good. This is right middle lobe pathology, like right middle lobe consolidation, right middle lobe collapse. Okay, if it is silhouetting the right heart border. If it is left heart border, it is going to be lingula. Okay, silhouette matlab border wala. Coming to the next one, the abdomen, that's the GIT part. What is the best X-ray view for pneumoperitoneum? Very good. It is chest X-ray erect, which is the best X-ray view for pneumoperitoneum to look for air under diaphragm. Okay, so very important X-ray, very frequently asked in the exam. This is the black air beneath the diaphragm that you are seeing. This is pneumoperitoneum. Okay, pneumoperitoneum. If not chest X-ray erect because the patient is in a very bad condition, then what X-ray view will you do? Will you say कि नहीं patient खड़े नहीं हो सकता तो अभी X-ray नहीं करेंगे, right? या पेशेंट को जबरदस्ती खड़े होकर हम एक्सरे नहीं निकालेंगे. पेशेंट, इफ द पेशेंट इज नॉट एबल टू स्टैंड, देन व्हाट विल यू डू? वेरी गुड, लैटरल डिक्यूबिटस. सुपाइन नहीं, लैटरल डिक्यूबिटस. कौन सा लैटरल डिक्यूबिटस? करेक्ट नमामि, इट्स गोइंग टू बी लेफ्ट lateral decubitus. Okay, left lateral decubitus is what you will do so that the air goes on the right side. Plus, if there is any air in the lesser sac also through the foramen of Winslow, it will go to the right side. Okay, so remember, it is left lateral decubitus which is done with a horizontal beam of X-ray. Okay, left lateral decubitus with a horizontal beam of X-ray. So look at this one. This is left side down and you are seeing this black air here rising onto the right side. This is pneumoperitoneum. Next one, Rigler's sign versus Rigler's triad. Where do you see Rigler's sign? Where do you see Rigler's triad? Rigler's sign, right? The distinct bowel wall sign, air within the bowel, air outside the bowel. This is seen in pneumoperitoneum, right? Versus where do you see Rigler's triad? In gallstone ileus, right? Frequently asked. Rigler's triad, you have ectopic gallstone, small bowel dilatation, obstruction, and you have pneumobilia, not hemobilia. Okay, it's pneumobilia that is seen. Correct. Okay, right? So look at this one. This is ectopic gallstone, the bowel loops which are dilated, and you would see air in the biliary tract. Okay, this is going to be Rigler's triad. Small bowel loop is called dilated if the diameter is more than 3 centimeters. Remember, you have 3, 6, 9 rule. Small bowel, large bowel, that's the colon, and the most distensible is the cecum. So, for 9 centimeters is the limit for cecum. 3, 6, 9. Okay, 3, 6, 9. Going to next one, coffee bean sign on abdominal x-ray is seen in what condition? Very, very frequently asked, was asked in the recent FMG exam also. Coffee bean sign, okay, coffee bean sign is basically in sigmoid volvulus. Okay, sigmoid volvulus is coffee bean sign. Absolutely right. Okay, correct. If there's a liver lesion which is calcified, when you see a calcified liver lesion, the first thing that you think of is hydatid cyst. Hydatid gets calcified in the liver. It shows water lily sign, the serpent sign, the membranes which are ruptured, partial rupture of the membranes showing the water lily sign. Okay, so water lily sign, serpent sign, calcified lesion, it is hydatid. If it is water lily sign, it is Garbi what stage and WHO what stage? Garbi. Remember, Garbi is by. It is Garbi ka stage 2. WHO 3 letter, 3 words. It is going to be stage 3. Okay. So, remember, Garbi ka stage 2 hai or WHO ka stage 3 hai. Okay. So, you have to remember this. Right. Correct. Going to next one. Where do you see football sign on abdominal x-ray? Football sign. What is forming that football? Yes. Very good. When there is massive pneumoperitoneum, you ask the patient to go supine and then you take a supine x-ray. All the air will come beneath the abdominal wall. So, this is seen in massive pneumoperitoneum. Massive pneumoperitoneum on a supine x-ray. Okay, it is seen in pneumoperitoneum on a supine x-ray where you will have this football appearance. Okay, right. Dr. Tamilvedan, if you have read this in NEC, necrotizing enterocolitis, remember the last stage when there is perforation happening leading to pneumoperitoneum. That is when you would see this. Okay. Inverted umbrella sign on BMFT. Inverted umbrella sign. So, this is the narrow terminal ileum. This is the widened gaping of the ileocecal valve which is there. This is seen in what condition? This is INI-CET exam question. Inverted umbrella sign. Correct SS. It is ileocecal TB. The stricture in the terminal ileum plus the widening, the gaping of the ileocecal valve, that gives the inverted umbrella sign. String sign. Where do you have the string sign? No, so I am coming to that. CHPS will give the string sign or even TB or Crohn's. Now remember, in radiology, what a string represent is, string matlab a narrow thread. Okay, so that basically represents narrowing, which can be seen in CHPS where the pylorus is narrowed, which is seen in TB where the ileum is narrowed, or even in Crohn's where the terminal ileum is narrowed, right? So remember, here in Crohn's it is specifically called as string sign of Cantor. Okay, both TB and Crohn's give string sign. In Crohn's Anukriti, remember Crohn's. Okay, remember Crohn's ko aap yaad kar sakte ho aap scale. Crohn's is Cantor, not TB. String sign of Cantor is Crohn's. Next one. What will be the barium enema sign in a child with red currant jelly stool? Barium enema sign in a child with red currant jelly stool. The red currant jelly stool basically represents intersusception. Okay, it represents intersusception. So, what are the barium enema sign? Right. Remember, one is the claw appearance. Okay, one is the claw sign and other is the coiled spring sign. Right, when you do put the barium, if there is intersusception, the barium will form a claw or the barium will go like a coiled spring around the bowel. Okay, correct. UST is where you see the target sign and pseudo kidney sign. Okay, correct, Shiravali. Barium enema is going to be claw and coil spring. What is the immediate management for intussusception? The immediate management is air enema. Okay, the immediate management is air enema. Correct. Next one. There's a child with non-bilious vomiting and there's olive lump in epigastrium, right? So this is CHPS. What is the investigation of choice for this CHPS? What is the investigation of choice? This is one of the NEET PG exam questions. The investigation of choice is going to be ultrasound. No radiation. You can measure the thickness of the wall, the muscle of the pylorus. So that is why UST. And how much should be the muscle thickness? More than 4 millimeters, not centimeters. More than 4 millimeter thickness, more than 16 millimeters long. Okay, so 4 and 4 square. Okay, 4 and 4 square. Next one, what is the most sensitive investigation for acute infarct? Coming to neuro, okay, the neuro part. Most sensitive investigation for acute infarct is it NCCT? Very good, Anonymous 007, correct, Dr. Debeki. Read the question very carefully. They're not asking you what is the first investigation that you would do. They're asking you that what is the most sensitive investigation, that it will pick up any acute infarct. That is what it means. Okay, so that's going to be DWI MRI, which picks up the infarct as early as within 30 minutes. CT will show normal, right, and early acute infarct. So the first investigation agar question hota to non-contrast CT. But most sensitive है तो DWI MRI. Acute infarct will show restricted diffusion. Kalai 98, remember SWI is for hemorrhage. DWI is for infarct. SWI is for hemorrhage. If there is a biconvex hemorrhage not crossing the sutures, biconvex EX, it is going to be extradural hemorrhage. EDH is going to be biconvex. Okay, EDH is biconvex and does not cross the sutures, middle meningeal artery rupture, right? This is how it appears. This is biconvex, not crossing the sutures, right? Acute hemorrhage is hyperdense. You can see it is appearing white. Okay. Next one. RTA, there's a patient of RTA with low GCS, but the CD scan is normal. Okay, the GCS is so poor, the GCS is worsening. You do a CT, but the CT appears normal. Then what do you think in that case? कि क्या है फिर patient को, trauma वाले को? Diffuse axonal injury. Correct. And what is the investigation of choice? MRI. What sequence in MRI? SWI. To look for the punctate hemorrhages, right? The tiny petechial hemorrhages, they are better seen on this SWI MRI, right? So remember, for DAI, it is MRI. Otherwise, in any patient of head trauma, the first you do is CT and not MRI. Okay, the first you do is CT and not MRI. Next one, where do you see, in which brain tumor do you see dural tail sign? Dural tail sign is seen in which brain tumor? Remember, dural tail. Dura is meninges. Okay, dura is meninges. It is seen in meningioma. Dural tail sign is seen in meningioma. Right? You would see a tumor which is extending along the dura like this. Dura is meningioma. When you have the 4 C's, a child with a central lesion, that's a midline lesion in the brain, which has cystic component, which has calcification, recent NEET PG exam question, machine oil जैसा content है. So what lesion are you thinking of? Correct. It is the 5th C, that is craniopharyngioma. Okay, it's a 5th C, that is craniopharyngioma, which is arising basically from the remnants of the Rathke's cleft Rathke's pouch, right? And that is craniopharyngioma. What is the location of this craniopharyngioma? It's a suprasellar location, right? Suprasellar related to pituitary, sellar, and that is why it can cause bitemporal hemianopia, right? Visual field defect it can cause is bitemporal hemianopia, very, very important. Okay, craniopharyngioma, correct. Next one, what do you think is the diagnosis here? What do you think is the diagnosis here? Oligodendroglioma? No. Very good, Shiravali. Correct. This is the newborn. Okay. This is a newborn. Right? There is a bulging anterior fontanelle and there's bruit on auscultation. Whenever there's a bruit, basically you're thinking of something vascular. Right? So, kuch vascular abnormality hai. There's a hypoechoic midline mass. The ventricles are dilated. That means there is hydrocephalus which is there. This is, we are talking about vein of Galen malformation. Okay, vein of Galen malformation, which is a AV fistula in the brain, which causes pressure on the heart as well. And remember, that is why the other history that you might have here is heart failure. Okay, a history of heart failure, hydrocephalus in a newborn, you will think of vein of Galen malformation. It's a AV fistula. Okay, high output cardiac failure hota hai. Correct. Next one, where do you see puff of smoke appearance on cerebral angiography? Right, you have the vessels, and from that vessels, you know, like the contrast goes out, like there is puff of smoke coming out from the vessels. Why is the contrast coming out? Because these are the new collaterals which are formed, which are leaky collaterals. Okay, the endothelium is not very good. So this is basically seen in moya. Okay, moya may you see this puff of smoke appearance, where it is ICA stenosis is there. The internal carotid artery is narrow, and that is why the body forms the collaterals. So you can remember this as dhua in moya. Okay, dhua like puff of smoke. So dhua is seen in moya. Correct. You will have a history of a young patient with stroke, right? Recurrent stroke history is there. Next one, you know the diagnosis here already. What is the diagnosis here? मोए nahi hai ye, moya. Very good. Stratosphere sign, this is going to be pneumothorax, right? The barcode or the stratosphere sign, this is going to be pneumothorax. Correct. Next one. Epidermoid can be differentiated from arachnoid cyst. Epidermoid cyst, arachnoid cyst. Okay, this is one of the previous, again, very previous AIIMS exam question. So, again, you should know this. Epidermoid cyst can be differentiated from arachnoid cyst in MRI. By what MRI sequences? What MRI sequence can help us to differentiate this? T1, T2 पे नहीं. Both of them are cyst, right? तो they will have fluid वाला थोड़ा component होगा, तो इसलिए T1, T2 similar होगा. तो कौन सा यूज करते हैं? Very good. One is flare. Why flare, Namami? Why? How flare would help? Very good. DWI and flare. Okay. Remember, the two sequences that can help us to differentiate are DWI and flare. If you look at epidermoid cyst and you look at arachnoid cyst. Now look at the term and tell me that which of these is containing CSF? Arachnoid. Arachnoid matlab CSF. Epidermoid matlab epidermis जैसा material. Remember, इसमें keratin जैसा thick material है. ठीक है? So what does a flare sequence do is it makes the CSF dark. So what will appear dark on flare is arachnoid. It will be suppressed on flare. Epidermoid is not containing CSF. It will not get suppressed. So that is how flare helps us to differentiate. Second, diffusion. CSF is free flowing like, right? So CSF does not show restricted diffusion. So again, arachnoid will not show any restricted diffusion. No restricted diffusion will be seen here with the arachnoid cyst. Epidermoid cyst will show restricted diffusion and it will not be suppressed on flare. Okay, the thick material not freely moving, it is restricted diffusion, restricted movement, restricted diffusion, right? So remember, the two important sequences here that you have are DWI and flare. Okay, DWI and flare. Okay. Next one, coming to the OBGY wala system, and then towards the end we have similar signs. You know, we'll be talking about like empty theca, empty delta, empty cella. Then you have popcorn calcification in brain, breast, lungs, right? So similar signs is what we will talk about towards the end. Normal mammography is by RADS. 0, 1, 2, 5. These are the options that you have. 0, 1, 2, 5. Right, very good. Remember, normal matlab none, abnormal none is 1 here in BIRADS. It is BIRADS 1, not BIRADS 0. 0 matlab inadequate study, right? Incomplete study, inadequate study. We need further imaging, okay? So 1 is normal. If there is microcalcification present, then you will call it BIRADS. Microcalcification is going to be BIRADS 5, highly suspicious of cancer. Okay, 2 is benign. Like fibroadenoma is 2. Okay, benign is 2. Okay, 1 is normal, 2 is benign. Double bleb sign is due to what two structures? In normal antenatal ultrasound, you have double bleb, two circular structures within the outer gestational sac. So, gestational sac is not forming the double bleb. It's a yolk sac, right? And you have the amnion. Okay, the yolk sac and the amnion. Right? So, yolk sac and amnion. Correct. Next one. So, coming to the similar signs that I was talking about. So, similar signs, where do you see empty delta sign? Empty delta. Delta is like a triangle. So, where is the empty delta sign? This triangle is the superior sagittal sinus, right? So, the superior sagittal sinus thrombosis on a contrast scan basically gives this empty delta sign. The thrombus does not allow the contrast to come in. So, this is the empty delta sign, superior sagittal sinus thrombosis. Because of that thrombosis, what has happened? The patient has got this hemorrhagic venous infarct. Okay, even the vein blockage, the draining vein blockage leads to the congestion in any organ, and that is why this is appearing more blood, right? It is appearing hemorrhagic. Okay. Next one, where do you have empty sella then? Where is empty sella? A cortical vein thrombosis per se will not give a empty delta, right? It is like, it is specifically the term used for superior sagittal sinus thrombosis. Empty sella, right? That basically means ये जो सेला है जिसके अंदर नॉर्मली क्या होना चाहिए? सेला के अंदर पिट्यूटरी होना चाहिए, बट वो नहीं दिख रहा है. तो उसके बदले में क्या दिख रहा है? There is CSF in the sella. Pituitary is compressed by the CSF, right? So what has happened is into the sella the CSF has gone. So where do you see that? एपोप्लेक्सी वहां पे तो आपको वहां पे दिखेगा ना, हेमरेज वगैरह दिखेगा पिट्यूटरी में. Pituitary apoplexy, correct. Where else basically you would see the CSF going into the sella, because the roof of the sella is torn apart by the raised ICT. Okay, any cause of raised ICT, intracranial hypertension. Okay, so that will lead to empty sella, pseudotumor cerebri, correct. Okay, so the raised ICT, you know, breaking this roof and the CSF is going in, it is seen in raised ICT. And where do you see empty theca? This is again one of the previous AIMS exam question. Where do you see empty theca? देखो थीका क्या है? थीकल सैक, स्पाइनल कॉर्ड वाले के अराउंड, राइट? कॉर्डा इक्वाइना स्पाइनल कॉर्ड के अराउंड जो है, करेक्ट. सो look at this one. What is happening is this CSF containing sac, the thecal sac is empty. You are not seeing any nerve roots here which should be seen. Why? Because arachnoid has got inflamed. The inflamed arachnoid fibrosis is pulling all the nerve roots towards itself, right? So remember, empty theca is seen with arachnoiditis. The inflamed arachnoid pulling the nerve roots towards itself, leading to the empty theca. Okay, it is seen in arachnoiditis. Next similar sign that we are going to talk about, right? Pruned tree appearance. Suddenly Sajad Bhatt ko good evening ma'am याद है? Hi, good evening. Right. Pruned tree कहाँ दिखता है? In the lungs and in the biliary tree. ठीक है, biliary tree पता है, PSC, primary sclerosing cholangitis. लंग में कहाँ दिखता है pruned tree? नहीं, TB में that is called as tree in bud. Okay, TB is tree in bud when there is active endobronchial spread. It's not TB. Pruned tree, basically in the lung, what does the pruned tree represent is the vessels are pruned. Okay, you are not seeing any vascularity in the peripheral 1/3. The vessels are getting cut, right? It is seen in pulmonary hypertension. Pulmonary hypertension, hypoxia, okay, vasoconstriction हो जाता है vessels का. So that gives a prone tree. Okay, it is pulmonary hypertension. And in the biliary tree, it is primary sclerosing cholangitis. Right, again sclerosing, it's like obliterating the tracts, right, the ducts there. So it is primary sclerosing cholangitis. Always remember the association with ulcerative colitis. Coming to the next similar sign, starry sky appearance in the brain and starry sky appearance in the liver. Where do you see starry sky appearance in the brain? Brain में से multiple ऐसे stars जैसे दिखता है. It is neurocysticercosis. Okay, neurocysticercosis, the calcified NCCs. And where do you see starry sky appearance in liver on USD? This is a previous FMG exam question. नहीं, Carolli's में नहीं. Carolli's is the central dot sign. Very good, Sanjeevni. Absolutely right. It is acute hepatitis. Okay. Acute hepatitis where the liver becomes dark because of so much of edema there, hepatitis. The liver becomes dark, the biliary, the portal radicals basically shine in the dark liver. Okay, that gives a starry sky in acute hepatitis. Okay, the dark liver because of the edema. Okay, acute hepatitis. Next one, where do you see the bird beak sign? On barium swallow and on barium enema. Burkitt's में starry sky. Correct. PSGN में starry sky. See, barium swallow is for esophagus. So, esophagus वाली pathology, that's going to be achalasia. बेरियम एनिमा में रेक्टम से जा रहे हैं और फिर बर्ड बीक मिल रहा है, मतलब यहाँ पे बेरियम स्टॉप हो रहा है बिकॉज देयर इज अ ट्विस्ट, राइट. द ट्विस्ट इज द सिग्मोइड वॉल्वुलस. Okay, the twist is the sigmoid volvulus. So, achalasia, barium swallow, and sigmoid volvulus is barium enema. Correct. Anonymous, Namami Som Subra, all of you. Correct. Next similar sign, soap bubble appearance. Where do you have soap bubble appearance? In the bone, in the brain, and in the abdominal X-ray. Very good. See, if it's a fused bone and it's an epiphyseal lesion, then it is giant cell tumor. Remember, like giant cell tumor occurs in a giant person, right? Adult person where the bone has fused, and it occurs in the epiphysis. Opposite of that, unfused and metaphysis, similar looking to GCT giving soap bubble, is aneurysmal bone cyst. Okay, aneurysmal bone cyst, giant cell tumor, both of them are expansile lesions. They look similar. So that is aneurysmal bone cyst. Very good, Sanjeevni. In the MRI brain, where do you have soap bubble appearance? ऐसे basal ganglia के region में soap bubble दिखेगा. It is cryptococomas. So cryptococcal infection in the brain, cryptococomas give the soap bubble appearance. And in abdominal X-ray, where do you see the soap bubble? Soap bubble in abdominal X-ray? Yes, even adamantinoma, that can give the soap bubble appearance. Pneumatosis intestinalis, rather. Soap bubble appearance is seen in meconium ileus. Okay, it is seen in meconium ileus. Meconium ileus associated with cystic fibrosis. Coming to popcorn calcification in the lung, in the breast, in the pelvis, in the bones. Popcorn calcification in the lung. Hamara tomara popcorn. Remember hamar tomar. That is hematoma. Okay, that is hematoma. In the breast, everybody knows it is fibroadenoma. Okay, in the breast, it is fibroadenoma. In the pelvis, again, this is a PYQ question. FMG में आया है. Postmenopausal female में calcified fibroid होता है. That gives popcorn calcification. Right? So, fibroid like fibroadenoma shows popcorn calcification. In the bone, popcorn calcification is generally seen in osteoid, osseous wale tumors या cartilaginous tumors. It is seen with cartilaginous tumors. Okay, like you have chondrosarcoma. ठीक है, chondro वाले tumors में दिखता है ये popcorn calcification in the bone. Okay, so remember it is not in osseous वाला but in cartilaginous वाला. कैसे भूल गए? Brain में Brain में it is seen in cavernoma, cavernous angioma. Cavernoma shows popcorn appearance in the brain. Very good, Dr. D. Correct. Okay. So this is about popcorn calcification. Coming to where do you have tram track calcification in the brain? Tram track. Okay. Following these two tracks. So what the calcification is following the gyral pattern. Tram track is seen in Sturge-Weber. Right, absolutely right. It is seen in Sturge-Weber gives the tram track calcification. Correct. And what is the classical history given in Sturge-Weber? Classical history given in Sturge-Weber is port wine stain with seizures, glaucoma. That's the classical history given there. And the tram track in the CT chest, okay, where you have the bronchi which are dilated. Bronchi dilated is bronchiectasis. Okay, that is bronchiectasis gives the tram track in the CT chest. Okay, tram track in the CT chest is bronchiectasis. Okay, coming to the central stellate scar. What renal lesion and what liver lesion will give the central stellate scar? Which renal tumor gives the central stellate scar? Very good, Sarah. You absolutely right. It is oncocytoma, which can give the central stellate scar, and in the liver. Very good, anonymous. What else? FNH, or it could be fibrolamellar variant of HCC as well. Focal nodular hyperplasia and fibrolamellar variant of HCC, both of them can give central stellate scar in the liver. Okay, in the kidney it is oncocytoma. Absolutely right. Yeah. Double density sign. Coming to the double appearance. Where do you have double density sign? कहीं पढ़ा है chest X-ray में double density? Double density chest X-ray में? Aspergilloma is the air crescent sign, right? Monod sign, air crescent sign. Where do you have double density? Right atrium, nahi. It is, yes, chromophobe RCC also can give the stellate appearance, like oncocytoma. Double density. If this is the heart, the left atrium enlarging, forming like another density, like overlapping the heart, forming the double right heart border. It is left atrial enlargement. Okay, left atrial enlargement gives the double density sign on chest X-ray. Okay, it is left atrial enlargement. The enlarged left atrium coming on the right side, like overlapping the entire heart, that gives the double density. Oh yes. Fungal sinusitis, right? So that is what I think, Nirday, you were talking about. Aspergilloma is the fungal ball in the lung. But if it is allergic fungal sinusitis, it can give the double density appearance. Okay, the fungus appears more hyperdense and you have the mucus as well. Right, mitral stenosis में होगा. Allergic fungal sinusitis में भी double density मिलता है. Allergic fungal sinusitis, which is also called the, you also get the serpent जैसा appearance, serpent sign. Next one, where do you have double PCL sign? If this is the knee MRI, right, you have the PCL here और उसके आगे एक दूसरा PCL जैसा दिखता है तो double PCL दिखता है. The double PCL is basically the another PCL like appearing structure is the medial meniscus which has stone. So the bucket handle tear of medial meniscus. Okay, bucket handle tear of medial meniscus is what gives the double PCL sign. Bucket handle tear of medial meniscus. Correct. Walking sign भी मिलता है on the lateral chest X-ray. Correct. The bronchial separation, the left bronchus getting elevated by the enlarged atrium. So the bronchus are not overlapping, but they form this V shape jaisa. That is called the walking man sign. Okay, walking man sign. Okay, coming to some dots and targets appearance. Okay, the other similar sign that we are talking about, you have the dots and the targets. Where do you get the central dot sign in the liver? Remember central dot sign, C for C, it is seen in Carolis. Central dot is seen in Carolis. Absolutely right. Where do you have eccentric dot sign in brain? Brain में कोई lesion है और उसके अंदर एक dot दिख रहा है. Eccentric dot, not the central dot, eccentric dot sign. Right, so this is the neurocyst with the sarcosis, the scolex within. Correct. This is seen in neurocysty sarcosis. So you are coming to that, the eccentric target sign. This we are talking about is the eccentric dot sign. The scolex appears like a dot. Okay, that is neurocysty sarcosis. Okay, while eccentric target is outer circle and the inner circle is eccentrically located. That is eccentric target sign. Remember, target T for T, this is seen with toxoplasmosis. Okay, eccentric target is toxoplasmosis, eccentric dot is neurocysty sarcosis. And where do you have the target sign in the abdomen? Inner circle, outer circle, target sign. Where do you have the target in the abdomen? Very good. One is intussusception. And where else can you have it? One is intussusception. And where else can you have it? Remember CHPS also, the narrow pylorus and the thickened pyloric muscle, that also gives the target appearance. Intussusception, inner bowel, outer bowel, that gives the target sign. Okay, so CHPS also and intussusception also. Right? Coming to the ventricles appearance, where do you get boxcar ventricle, racing car appearance and bat wing fourth ventricle? Boxcar. Okay, box ऐसा है box. तो basically क्या हो रहा है कि आगे के चक्के पीछे के चक्के same है. Right? So where do you get the boxcar? The frontal horns are getting dilated because there is caudate atrophy in Huntington's chorea. Right? Huntington goes for hunting in a boxcar. और रेसिंग कार किस में मिलता है? रेसिंग कार इस पीछे के चक्के ज्यादा बड़े हो गए इन रेसिंग कार. ठीक है, so remember racing car is RAC, racing R, A for agenesis, C for corpus callosum. It is seen in agenesis of corpus callosum, RAC. Okay, agenesis of corpus callosum. Aicardi syndrome is associated with corpus callosal agenesis. So that's why it can have this racing car. So primary cause is corpus callosal agenesis. And where do you have bat wing fourth ventricle? Bat wing fourth ventricle. So the fourth ventricle is appearing like a bat wing. Okay, or even it can appear like an umbrella. Very good. That is seen with Joubert. Okay, Joubert, where there is elongated superior cerebellar peduncles, वर्मिस नहीं है, वहां पे आपको ये दिखता है bat wing appearance of fourth ventricle. Coming to figure of 8 appearance, where do you have figure of 8 in heart, brain and pituitary? Figure of 8 हमने heart में already देखा हुआ है. Supracardiac TAPVC, right? Type 1 TAPVC, snowman heart. Where do you have brain में? Yeah, Joubert has a molar tooth appearance because of the elongated superior cerebellar peduncles, right? You get the molar tooth there. In the brain, where do you have figure of 8 appearance in the brain? So this is a brain which is appearing like a figure of 8. So what does it mean that the brain surface is a smooth surface with just a shallow sylvian fissure? Brain में, हम pituitary में बाद में आ रहे हैं. Brain में this is seen in lesencephaly. Okay, in the brain it is seen in lesencephaly, a smooth surfaced brain, lesencephaly. Very good, Kalai. And in the pituitary, if this is the sella and there is a mass growing beyond the sella as well, giving this figure of 8 appearance, it is pituitary macroadenoma. Pituitary macroadenoma growing beyond the sella, that will give the figure of 8. Yes, figure of 8 in microbiology is blastomycosis. Okay, that's blastomycosis. Correct. Coming to signet ring sign, where do you have signet ring sign in the chest and on IVP? Signet ring sign in the chest and on IVP. Snowman appearance is same like figure of 8, right? They are interchangeable terms. Signet ring in the chest, dilated bronchus, smaller vessel, that is bronchiectasis. Okay, that is bronchiectasis. And in IVP, this is one of the previous FMG exam PYQ. Signet ring on IVP. Very good, Sarayu Nirdai, correct. It is seen in renal papillary necrosis. Okay, the papillary necrosis, the central papilla which is necrosed will not pick up the contrast, but surrounding that you have the contrast there. Signet ring is seen in renal papillary necrosis. Okay, renal papillary necrosis. Correct. Right. So I believe that was the last slide that we had here. Okay, in the one-liners, the last part that we had was very interesting, right? The similar signs that we spoke about, same term sign, but in the various organs, the various parts of the body, right? So that was about a quick revision of the most important signs and the appearances in radiology, guys. I hope you enjoyed this session and it was a quick revision for everyone. Thank you so much for joining in. I'll see you again soon. And till then, goodbye, take care, and keep studying, keep revising, and keep winning. Thank you so much. डॉक्टर डिबे की मिड गट वॉल्वुलस में बर्ड वीक नहीं होता है. मिड गट वॉल्वुलस इज दैट the corkscrew appearance of the duodenum is what you get. Midgut is where the duodenum is affected. That gives the corkscrew appearance of the duodenum. Okay. Yes, Dr. Kiran, you just supplement with the previous PYQs, right? So to understand what kind of questions are asked. Because radiology, if you look at the questions, they are more, asked in depth, and they are becoming more eccentric. The questions that, you will not generally expect. So if your basic knowledge of radiology, the black and white is good, then, you should be able to solve those questions. Okay. All right. Thank you so much, everyone. Thank you. And I'll see you again soon. Thank you so much.